Good day. Welcome to the lecture on tumors of the central nervous system. So, the WHO classification of tumors of the CNS lists more than around 120 types of brain tumors. So, this is an evolving process with obsolete entities being discarded and new recognized tumors added with each successive revision. So, the present classification remains, again, based on morphology, histology, and is increasingly being complemented by genetic characterization of neoplasms. So, patients with CNS tumors usually have a specific neurologic presentation. So, if a tumor is on top of the motor strip or impinges on the motor strip or causes damage to the motor strip, you can have progressive neurologic deficits such as motor weakness. Signs of increased ICP brought about by the tumor will be headache with nausea and vomiting. And again, as the tumor irritates the cortex, you can have seizures. So these are a few of the neurologic manifestations of tumors. So now there are different types of tumors. For now, we will classify them based on their location. So you have your supratentorial tumors, which are tumors located in your cerebral hemispheres. So these tumors are most likely to cause increase in ICP due to the mass effect of the tumor, the perilesional edema associated with that tumor, and if the tumor impinges on your CSF pathways, such as a thalamic glioma or anything that will cause impingement in your aqueduct, your Sylvian aqueduct, could cause hydrocephalus. And again, as mentioned earlier, progressive focal neurologic deficits brought about by the tumor's damage or compression with your motor pathways or even your sensory pathways. If the tumor is located on the left side, which is the dominant lesion, the dominant hemisphere of majority of the people in the world, you can have aphasia. And of course, seizures being cortical irritants, tumors being cortical irritants can bring about seizures and mental status changes. So patient's inability to remember things, the patient's inability to respond adequately or properly to questions. So these are supratentorial tumors. Now for infratentorial tumors, so these are tumors that most likely affect the brain structures that are beneath the tentorium cerebelli. So you have your cerebellar hemispheres, CP angle area, or brainstem tumors. So seizures are rare when for tumors of the infratentorial region because there's no cortical irritation. Increase in ICP due to hydrocephalus is very common due to the blockage of the CSF pathway, most likely the fourth ventricle or the aqueduct of Sylvius. And then you will also have gait disturbance, ataxia, dysmetria brought about by tumors of the cerebellum, and of course vertigo as well. So these brain tumors are need to be identified via different imaging modalities. So an example of neuroimaging would be CT scans or an MRI, which is an important step in the initial diagnosis of a brain tumors. And the ability of imaging to non-invasively localize characteristic brain tumors can facilitate treatment planning. So imaging also plays a role in determining the extent of resection following surgery, as well as monitoring treatment response after chemotherapy or radiation therapy. Now, as a neurosurgeon, CT scans and MRIs have really helped me initially diagnose the patient, and once the patient is amenable for surgical resection, CT scan with contrast, or as the gold standard, MRI with contrast, really helps us in surgical planning, in assessing the proper corridors that we will use to avoid as little damage to the normal brain as possible when excising a tumor. Now, the decision for which imaging modalities are used during initial workup with suspected brain tumor surgery largely depends on the clinical history and the availability of scanners. Uh, Given our situation, there was a time here in the city where we didn't have a functioning MRI. So all tumors were diagnosed just on the basis of a CT scan. So a patient presenting to the emergency department with active seizures would typically be subjected to a CT scan in the acute setting. Then a patient presenting to a medical clinic with headaches may instead be studied initially with with an MRI. CT performed only to address specific questions related to bony lesions or calcifications. Now, as I'm not sure if it was discussed with you in neuroimaging modalities of the CNS, but if a patient presents with acute symptoms such as severe headache, nausea, vomiting, that's causing him to have decrease in sensorium or very active seizures, you would choose the modality that is suitable for that emergency setting, which is a CT scan. It's fast, it's efficient, and if the patient is intubated, you can still get imaging modality of you can still assess what is going on in the patient's CNS. An MRI would have to be used for patients that are more stable, that are being treated or are being assessed on an elective basis, because an MRI will take longer. And of course, you cannot have any, if the patient's intubated or has a lot of contractions, he may not be MRI compatible. So differences between CT and MRI in terms of sensitivity to parenchymal versus bony lesions and safety profile. Not to mention cost and availability in this era of limited medical resources are complex. That is, it is impossible to uniformly declare one modality clearly superior to the other. The clinical practitioner must be aware of the differences between these two technologies and should rely on the radiology consultant for advice in case cases are difficult. Now, to get on the more specifics of an MRI, so an MRI will provide exquisite soft tissue contrast and lack of ionizing radiation, which will make it the imaging modality of choice for evaluation of CNS tumors. A non-contrast enhanced MRI can often detect and characterize small brain lesions on the basis of intrinsic differences in magnetic relaxation properties of tissues, as well as the presence of associated edema. Contrast MRI allows detection of a very small parenchymal or meningeal lesions, which is 1 to 2 millimeters in size, that may significantly affect clinical decision making. Now, a CT scan, because of the similarity in radiographic density between brain tumor and normal brain, small brain tumors may not be detectable by CT. But CT has clear advantages over MRI, however, when it comes to visualizing bony-centered lesions only. CT imaging of the bony matrix can demonstrate patterns that can help identify the underlying pathology. And CT may be the only available option if the patient has contraindications to MRI, such as a cardiac pacemaker, ferromagnetic foreign bodies, implants, and surgical devices that cannot be removed or replaced. The general imaging approach to patients with brain tumors consists of the following steps. So first, you need to identify if there is mass effect brought about by the tumor, and then you need to localize the tumor and locate it within the distinct regions of the brain. And then analysis of imaging features within and around the lesion. If there is calcification, if there is hemorrhage within the tumor or surrounding it, as well as its associated, if there are blood vessels associated with the surrounding, in the surrounding region. So again, there are two types of tumors, intraaxial and extraaxial brain tumors. An extraaxial brain tumor, as it says, it is outside of the brain, compressing the brain. So extraaxial masses frequently exhibit the following characteristics. Displacement or compression of adjacent cortex, cerebrospinal fluid or cortical vessels between mass and brain, contrast enhancement and thickening of dura, leptomeninges or cranial nerves, or invasion of adjacent bone. In this slide, we see an example of an extraaxial tumor. Now, an extraaxial tumor, let me pull out a pointer. There you go. Now, an extraaxial tumor, as you see, compresses the underlying brain. And as mentioned earlier, you have a CSF cleft. And here, this is the dura, you have dural thickening. Most likely, this tumor is a meningioma. This is an MRI, and this is an example of a CT scan of a meningioma. Again, there is association to the underlying bony cortex. And although the dural thickening isn't clear here, but you clearly have a CSF cleft here. And then it compresses the underlying brain parenchyma. Now, an intraaxial tumor location will show the brain tumor contained within the brain parenchyma. All the margins of the lesion are contained within the brain parenchyma, and you have expansion of the underlying brain cortex, or you have perilesional edema. So these are examples of intraaxial brain tumors. As you can see, most common intraaxial brain tumor is your METS, cerebral metastasis, or your glioblastoma multiforme, or GBM, WHO grade 4 glioma. So these are the tumors contained. These are intraaxial tumors. As you can see, all its margins are contained within the brain parenchyma. Another type of MRI that helps us differentiate between high-grade tumors, low-grade tumors, or infectious entities is magnetic resonance spectroscopy. So it's non-invasively measures concentrations of tissue metabolites and has shown promising application in the evaluation of brain tumors, including their diagnosis, grading, pre-therapy planning, and post-therapy assessment. The most commonly analyzed metabolites in brain and brain lesions include N-acetyl aspartate, choline, creatine, myoinositol, and lactate and lipid. So NAA, or N-acetyl aspartate, is a neuronal marker that decreases in concentration in most known brain pathologic conditions that damage neurons, including tumors, inflammation, and infection. And choline, this marker is very important to us, is a marker of cellular turnover and is typically elevated in neoplastic processes because of the increase in cellular proliferation. So meaning, if you do an MRS on a glioblastoma multiforme, you will see a choline spike because it is a marker for a neoplastic process. So elevation in the choline-NAA ratio in the peritumoral region can be a sign of tumor infiltration rather than edema induced by tumor. And this finding may allow differentiation of high-grade gliomas to brain metastasis. Now, this is an example of an MRS. As you can see, let me pull this up. As you can see, this voxel, or this voxel is being studied, and you can see that there is a choline spike in this area, meaning there is high cellular turnover, meaning that this is most likely neoplastic process. Now, moving on. So these are the different, again, an overview of the different types of CNS tumors. So an astrocytoma is a brain tumor that exhibits purely astrocytic differentiation and can be separated into two major categories: diffused or circumscribed. Complete surgical resection is rarely attained with diffuse astrocytomas because of inherently infiltrative nature of the neoplastic cells, which extend well beyond the apparent gross margin of the tumor. So an example of an astrocytoma is your WHO grade 1 pilocytic astrocytoma. Now this typically arises in children and young adults. It's macroscopically circumscribed and grows very slowly. It exhibits very little tendency for anaplastic progression, and sometimes it manifests as a mural nodule. So Rosenthal fibers, which are bright eosinophilic compact masses of glial intermediate filaments, are entrapped within cytosolic and protein and eosinophilic granular bodies. And these are the EGB, the eosinophilic granular bodies, are histologic hallmarks of pilocytic astrocytomas. Now, apilomyxoid astrocytoma, which is a WHO grade 2, this is a newly recognized variant of pilocytic astrocytoma, apilomyxoid astrocytoma rather, are clinically more aggressive and than your ordinary pilocytic astrocytoma. And the hallmark, histologic hallmark, as the eosinophilic granular bodies and the Rosenthal fibers, which are found in the pilocytic astrocytoma, are very inconspicuous here, or actually absent. Now, despite their benign morphologic appearance, diffuse astrocytomas have an intrinsic tendency to recur, spread extensively, and undergo anaplastic progression to a higher grade. Anaplastic progression is especially true of the gymnastiocytic variant of pilocytic astrocytomas. Now, moving on to WHO grade 3 astrocytoma, the anaplastic astrocytoma, which is a hypercellular glioma composed of poorly differentiated astrocytes consisting of a mixture of pleomorphic fibrillary and gymnastiocytic cells with significant nuclear atypia. Now, this may develop as a result of an anaplastic progression from a pre-existing low-grade diffuse astrocytoma, which we spoke about in the previous slides. And they typically show anaplastic progression to glioblastoma after an average of 2 years. So the grade 3, WHO grade 3 anaplastic astrocytoma may progress to a WHO grade 4 glioblastoma multiforme. And speaking of the glioblastoma multiforme, the glioblastoma multiforme is the most common glioma and the most malignant primary brain tumor arising in adults. The most common malignant brain tumor being the METs, but the most malignant primary brain tumor is the GBM. Solitary tumors of the cerebral hemispheres, these are solitary tumors but may develop at almost any site within the neural axis. In many cases, these infiltrate across the corpus callosum or arise directly within it with bilateral extension called the butterfly glioma. These are the only gliomas that cross the midline towards the contralateral hemisphere. Infiltrating glioma cells can be easily identified microscopically well beyond the apparent cross-tumor boundaries. So mitotic figures are typically readily identified, and corresponding proliferation marker indices such as Ki67 antigen will show elevated levels. Microvascular proliferation and foci of necrosis are histologic hallmarks of GBM. The presence of necrosis is not required for a diagnosis of GBM, but according to the WHO 2007 criteria, vascular proliferation in conjunction with pleomorphism and increased mitotic activity will be sufficient enough to diagnose GBM. Now, on to the difference between primary versus secondary GBM. It's quite simple. Primary GBMs arise de novo without evidence of a pre-existing low-grade astrocytoma being present prior, typically in patients in the 6th decade of life. Epidermal growth factor receptor gene amplification occurs in about 40% of primary GBMs. Secondary GBMs tend to develop in younger adults by a malignant progression from a diffuse astrocytoma WHO grade 2 or 3, which is the anaplastic astrocytoma. And the genetic hallmark of a secondary GBM is your TP53 mutation. So for a primary GBM, your gene amplification or your genetic hallmark will be your epidermal growth factor receptor. So oligodendroglioma, this is another type of intraaxial brain tumor, classified as WHO grade 2. Is a well-differentiated, diffusely infiltrating tumor composed of cells resembling normal oligodendroglia. Preferential location of these tumors is the white matter of the cerebral hemispheres, from which tumor cells typically infiltrate the overlying cortex. These are composed of uniform round cells with cleared cytoplasm surrounding a central spherical nuclei, giving it a fried egg appearance. So oligodendrogliomas have branching networks of small, delicate blood vessels, otherwise known as a chicken wire pattern, which is its histologic feature. And microcalcifications are also known within the tumor. So for the WHO grade 3 type of oligodendroglioma, the anaplastic oligodendroglioma, it just has high-grade features and shows increased mitotic activity with microvascular proliferation or necrosis. A hallmark genetic signature of an oligodendroglioma is combined whole arm deletion of chromosome 1p and 19q. Um, this was asked in our exam. But yeah, so that is a genetic signature of oligodendroglioma. Oligoastrocytoma WHO grade 2 and anaplastic oligoastrocytoma WHO grade 3 are currently regarded as mixed diffuse gliomas with astrocytic and oligodendroglial components. So ependymoma, which is classified as WHO grade 2, is a slow-growing neoplasm of children and young adults that originates from the ependymal lining of cerebral ventricles. An infratentorial location is most common in children, and for adults, it's most commonly located in the supratentorial component. So ependymomas may occur outside the ventricular system in the brain, parenchyma, and also in the spinal cord. Ependymomas are grossly characterized by a sharp demarcated edge, and its histologic hallmark of perivascular pseudorosettes. It has a histologic hallmark of perivascular pseudorosettes. So anaplastic ependymomas, which are given the classification of WHO grade 3, typically show increased mitotic activity and microvascular proliferation. Ependymomas of the spinal cord, a certain type called the myxopapillar ependymoma, is a distinct low-grade variant of ependymomas that arise almost exclusively in the conus medullaris or phylum terminale. Surgical resection of intact tumors can be curative in some cases. I've experienced a couple of spinal cord myxopapillar ependymomas that were located in the phylum terminale region. They are resection does provide cure. Now we also have choroid plexus tumors. So you have your choroid plexus papilloma, your atypical choroid plexus papilloma, which is WHO grade 3, and your choroid plexus carcinoma. Now, these originate from the epithelium of the choroid plexus of the cerebral ventricles, and the lateral ventricles are more often involved in patients younger than 20 years old. Now, choroid plexus tumors, most intraventricular choroid plexus papillomas are benign and can be cured with surgery. Dissemination via the CSF can occur in up to 20% of the cases. So these tumors may spread within your CSF pathways. Now, germ cell tumors, or germinomas of the CNS, which are classified as WHO grade 3, have a proclivity to affect midline structures, particularly the pineal region and the third ventricular region. Characteristically, these exhibit a biphasic cell population, very large malignant cells, resembling primitive germ cells and small reactive lymphocytes. Patients may be treated with radiation, chemotherapy, or a combination of both. Now, on to embryonal tumors, an example of which is your medulloblastoma, which is classified as WHO grade 4 and is the most common intracranial embryonal tumor and by definition arises exclusively in the cerebellum. You see a peak incidence at 7 years, but there's a second peak incidence in adulthood at around the age of 21 to 40 years old. Childhood medulloblastomas usually arise in the midline vermis, where adults usually have medulloblastomas arise in the cerebellar hemispheres. Now, prognostic indicators of poor clinical outcome are the following. So, age younger than 3, CSF dissemination at diagnosis, partial surgical resection, or the larger anaplastic variant. Moving on to another type of tumor are your tumors of the meninges, or I think we're all familiar with these, the meningiomas. So these are slowly enlarging neoplasms that originate from meningothelial arachnoid cells. They're typically firm, attached to the inner surface of the dura, may originate in any location where arachnoid cells are present, including the choroid plexus, which is why sometimes you have your intraventricular meningiomas. They arise most frequently in women in the middle decades of life, and most meningiomas are well-defined lobulated masses that compress the underlying brain. So, invasion of brain parenchyma is associated with greater likelihood of recurrence. Invasion through the dura into the overlying cranial bone is quite common in low-grade WHO1 meningiomas. And again, the WHO subdivides the meningiomas into 3 different grades. So your benign, your atypical, and your anaplastic. Now, for tumors of the sullar region, you have an example of which will be your craniopharyngioma. So it's classified as WHO grade 1. It's an epithelial tumor of the sullar and suprasellar regions, presumably derived from the Ratkes pouch remnants that occur predominantly in children and young adults. It has 2 types, your adamantinomatous and your papillary. Cystic cavities characteristically contain a dark viscous fluid that has been likened to machinery oil. When you open these tumors up, you will see dark viscous fluid, as I think I have in my next slide an example of a patient we operated on before. Oh yes, so this is, how old was he? I think he was a 5-year-old that we diagnosed to have a craniopharyngioma. So we tried to excise the entire thing, but I think we only got 70% of the brain tumor. This was a 5-year-old. Yeah, this was during our my residency training in UST. Now, again, I just wanted to show you this MRI to see that the significant compression of the suprasellar mass onto the brain parenchyma, causing significant neurologic deficits in this case. So the CNS is also plagued by metastatic tumors coming from different parts of the body. Now these are often located at the gray and white matter junctions of the cerebral and cerebellar hemispheres, but these may affect any part of the CNS. So most common primary sites of origin are the lung, breast, skin, kidney, and GI tract. And oftentimes, the CNS tumor may be the initially detected feature of the primary cancer. Then once we see on the imaging modality that it seems like it's metastasis via CT or MRI, then we can initiate the search for a primary tumor. Carcinomas of the GI tract, breast, prostate, and uterus often produce solitary mets, while multiple brain mets are frequently associated with cancers arising in the lung from melanomas, and when the primary cancer site is unknown. Now, for dural metastasis, for isolated dural metastasis, the most frequent origin is breast cancer. So now we will be moving on to the different types of pathologies. So we're going to divide CNS tumors into intraaxial CNS tumors versus extraaxial. Then I'll try to give you the most explain in depth the most common tumors that I or you will encounter as a medical practitioner in the future. Okay, hello. So we're back. So now we'll be discussing specific intraaxial CNS tumors in depth, just to give you a little bit more information about them, tackling how the different diagnostic imaging findings with regards to specific tumors, as well as treatment options. Okay, so as discussed earlier, we will go about intraaxial first, then extraaxial. So our first intraaxial CNS tumor is a low-grade glioma. The most common initial presentation of patients with low-grade gliomas are seizures, which is 65 to 95%, followed by headaches. Symptoms from tumor mass effect are comparatively less common. Slow growth rate on average, around 4.1 millimeters per year, has been noted. Seizure prognosis is determined by the extent of resection, preoperative seizure control, duration of seizures, and seizure types. So pretty much, if the gist of this statement is seizure control is accomplished, or seizures will be addressed or will be treated if you have a significant amount of resection, or if these seizures preoperatively were already controlled by medications, by anticonvulsants, how long the seizures have been occurring pre-op and post-op, and the type of seizure, focal versus generalized tonic-clonic. Now, corticosteroids, or steroids, in this specific case, dexamethasone, are often administered to manage symptoms produced by tumor-associated mass effect and vasogenic edema. Steroids will counteract the effects of vasogenic edema, thereby decreasing the perilesional edema, decreasing the pressure and the ICP inside the brain. So again, steroids have been shown to reduce vasogenic edema and apparent volume when gliomas are imaged with computed tomography, or CT. Diagnostic imaging of gliomas, you can do a CT scan, but of course the gold standard is an MRI. They demonstrate lesions that are iso-intense or hypo-intense on T1 and are homogeneously hyper-intense on T2. So they are just, they're dark on T1, to put things simply, and they are bright on T2. And usually low-grade gliomas do not enhance with contrast administration, and calcifications can be detected in about 20% of lesions and appear as distinct hyper-intense foci on T1 weighted image. So low-grade gliomas, usually, if they have calcifications, it's only about 20%. Vasogenic edema and necrosis, again, are not typical of low-grade gliomas. So these are necrosis and significant vasogenic edemas. Edema is usually associated with a higher grade, such as anaplastic or glioblastoma multiforme. So there's also an increase in choline creatinine ratio and MRS, and also corresponds to a heightened risk of So if you have a high choline spike, that means you just have high cellular turnover. It means that tumor has a heightened risk of transformation into something more malignant. So this is an example of an MRI of low-grade glioma. So again, as we mentioned, I am not sure if you're familiar with different sequences in MRI, but just to give you a basic, just the gist of it, let me pull out a pointer. There you go. So this is T1, T1 and T2. So water is white in T2. So this is your CSF. So it's white, and water is dark on T1. So this is your CSF. It's dark. So T1. It's a hypo-intense lesion. This is a low-grade glioma. On T2, it's hyper-intense. Quite simple like that. So functional MRI, which is another type of MRI, which just has a different sequence and uses blood flow. This is based on the increase in blood flow to local vasculature that accompanies the neural and metabolic activities of the brain. This increase results in a corresponding local reduction in deoxyhemoglobin because the increase in blood flow occurs in the absence of a comparable increase in oxygen extraction. Now, the endogenous contrast-enhancing agent used here for a functional MRI is deoxyhemoglobin. Take note of that. So treatment options, you have an observation. So this strategy differs treatment-related risk and treatment-related costs. It may increase the risk of tumor progression and the subsequent development of new neurologic deficits, such as intractable seizures as well, and as the risk of malignant dedifferentiation of the lesion. So by just observing, there is a risk that it might transform to something more malignant. And of course, the risk of having seizures and neurologic deficits will always still be there. Now, tumor growth rates can be unpredictable and are often nonlinear, so leading to sudden changes in tumor size that can drastically change the surgical landscape. and turn an intractably resectable or radio-responsive lesion into a tumor that is difficult to remove safely and is more resistant to adjuvant therapy. So as the tumor gets bigger, it just gets more difficult to take it out. And as the tumor gets bigger, the chances of it responding to your either chemo or radiotherapy get smaller. Now, another treatment option is biopsy. So either stereotactic, so you're image guided, or it's open biopsy. So choice depends in part on the patient's clinical status, the anatomic location of the tumor, and the surgeon's preference. And of course, the technology that's available to us. When I was in UST for my residency, we had the Brain Lab, which was stereotactic guided imaging, which made us, excise tumors stereotactically with image guidance. We don't have that here, unfortunately. So most of our biopsies or our excisions are open. So the goal of surgical intervention includes establishing a diagnosis, treating neurologic symptoms, decompressing the mass effect, and cytoreduction of tumor. Cytoreduction, by lessening the malignant cells, you give the tumor better chance of responding to chemo or radiation therapy. The only agreed upon surgical standard for adults with suspected or known supratentorial non-optic pathway low-grade glioma is to obtain a tissue diagnosis before active treatment commences. Now, treatment options such as microsurgical resection. So we only offer this to low-grade gliomas that are accessible and have symptoms of local mass effect, increased intracranial pressure such as headache, nausea, and vomiting, or decrease in sensorium, or intractable seizures that do not respond to any medications. So alleviation of mass effect, cytoreduction, and of course to give us diagnosis. Cytoreduction can also reduce cerebral edema and potentially improve sensitivity and chemosensitivity of the tumor. The primary tenet of any surgical approach to gliomas is maximal resection with minimal morbidity and mortality. And a balance between the extent of resection and functional preservation must be established. So there is no point in removing a tumor if the patient cannot walk afterwards. So you have to consider functional capability of the patient as well as a resection of tumor. Very important. So another treatment option is radiation. So post-operative radiation treatment does not increase overall survival relative to observation alone, but it does confer superior progression-free survival in patients with low-grade glioma. So these studies have just noted that patients who underwent radiation have a better progression, have less progression of the tumor. So they have a progression-free survival. And patients who were treated with a higher dose of radiation had obviously more side effects and lower survival rate. Now, chemotherapy for low-grade gliomas, the agents used for treatment are temozolomide and PCV. Temozolomide is an oral agent that functions by alkylating DNA and impairing cell division. So for patients with WHO grade 2 gliomas undergoing less than gross total tumor resection or older than 40 years old, it was noted that PCV plus radiation therapy prolongs both overall survival and progression-free survival relative to RT alone. So chemotherapy works synergistically with RT to help survival of patients with low-grade gliomas. So moving on to malignant gliomas. So this is these are your anaplastic astrocytomas and glioblastoma multiformes. So the most common primary brain tumor in adults is your GBM. So even with optimal treatment, median length of survival is less than 2 years for patients with glioblastoma and 2 to 5 years for patients with anaplastic gliomas. The average age at which anaplastic astrocytomas develop is around 40, as mentioned on the previous slides, and glioblastoma has a mean age of onset of around 50 to 60 years old. Glioblastoma is more common in men, with a male to female ratio of 1.5:1. Unlucky for men, I guess. So these glioblastomas usually occur in the cerebral hemispheres. They're more common in the supratentorial compartment. They can arise from low-grade astrocytomas. Again, these are the secondary GBMs, but can also be diagnosed at de novo at first biopsy without any signs of a malignant precursor. Now, though without malignant precursors, your primary GBM. So patients commonly have raised ICP, intracranial pressure, which leads to headache, nausea, and vomiting. And this intracranial pressure can lead to blurred or double vision and eventually drowsiness. So these gliomas are lethal because they grow by invasion into otherwise normal brain tissue, which makes them very difficult to excise. And these gliomas actually even cross midline to the contralateral cerebral hemisphere, which again makes excision significantly difficult. And to even when using a microscope, it may be difficult to excise these tumors without the guide of your 5FU. So infiltration of tumors into eloquent areas of the brain may limit the extent of tumor resection. Now, to go on to the WHO grading of gliomas, you have your WHO grade 2 tumors, which may have nuclear atypia, WHO grade 3 tumors, which display mitotic activity and nuclear atypia, and your WHO grade 4 tumors, which show nuclear atypia, mitosis, and the vascular or endothelial proliferation or necrosis. Now, as mentioned earlier, diagnostic imaging modalities for intraaxial tumors or for any tumors of the CNS most likely will be the MRI. CT is used in the acute environment as the first line of imaging to exclude hemorrhage or large areas of infarction in the brain. So, if the patient comes to the emergency room deteriorated, seizing, the first thing you should, even if you're suspecting a brain tumor, the first thing you should do is just get a CT. Then after that, you can get, stabilize the patient and get more definitive imaging via an MRI once the patient's more stable. Or if you ruled out any emergent surgical lesion. Okay, so CT is particularly adept at delineating acute hemorrhage as well as intratumoral or skull classifications. Now, MRI is used to better characterize the mass because of its multiplanar capability and superior soft tissue contrast. So the MRI will help us identify the different structures beside the tumor, different landmarks that we can use or that we can avoid in relation to the tumor. And gadolinium contrast agent can enhance soft tissue contrast, so which will further elucidate the boundaries of the tumor and provide information about the integrity of the blood-brain barrier by detecting areas of blood-brain barrier breakdown. High-grade gliomas normally appear as irregular hypodense lesions on T1 weighted MRI with various degrees of contrast enhancement. So they don't enhance as a whole. Some of them enhance as a whole. Some of them have heterogeneous enhancement, meaning just certain areas of the tumor enhance with gadolinium contrast. And the presence of a ring-like enhancement surrounding irregularly shaped areas of presumed necrosis is usually suggestive of a GBM. So as we can see in this picture, these are GBMs. So these are intraaxial tumors, so all the borders are within the brain parenchyma. You have ring-like enhancement after contrast administration surrounding an area of necrosis. You have peritumoral edema, this hypo-intense area around the lesion. So this is an MRI. Again, T1 weighted, water dark on T1 with contrast enhanced agent. So this is a contrast enhanced T1 MRI sequence. So medical treatments for GBMs. Unfortunately, no evidence that prophylactic anti-epileptic drugs are beneficial in patients with brain tumors who have not had seizures. Now, peritumoral edema is frequently treated with corticosteroids, as I mentioned earlier, such as dexamethasone. And patients with malignant gliomas are also at risk for venous thromboembolisms from leg and pelvic veins, so you should give low molecular weight heparin. Now, surgical treatment of malignant gliomas, you have 4 goals of surgery. So number 1 is you always obtain tissue diagnosis. By excising the tumor, you can have decrease in mass effect. And by removing a significant amount of the tumor, if not all, you can reduce the tumor burden, make the tumor bed or the remnants more responsive to adjuvant therapies, and of course, increase the survival and quality of life. There is increasing evidence that favors maximal resection with minimal residual tumor over biopsy alone. Now, extensive resection theoretically decreases the number of remaining cells, renders the decreased tumor burden more responsive to adjuvant therapy, and potentially prolongs survival, as I mentioned earlier. Now, chemotherapy and radiation therapy that are used for high-grade gliomas, you have your carmostin-loaded biodegradable polymers have been known to lengthen survival in patients with recurrent malignant gliomas from 23 weeks to 31 weeks after revision resection. I haven't seen these polymer wafers yet, but usually based on the book, these wafers are placed in your resection cavity, and they're able to release chemotherapeutic agents within the cavity post-op. And also, there is a prospective randomized controlled study by Stoop and colleagues. So this is the Stoop protocol. We as neurosurgeons, we know this by heart because we have to explain the median length of survival to patients that we diagnose to have GBM. So once we put them on the Stoop protocol, and this is by far the best protocol that we've had. So they demonstrated longer survivals, which is around 14.6 months, in patients with glioblastoma who underwent surgical resection along with RT and temozolomide chemotherapy. So 14.6 months. But in my personal practice, I've seen more. I've seen some patients live for more than 2 years on chemo RT, on new adjuvant chemo radiation therapy. But I guess this is the the entire population. They had a median survival period of 14.6 months. I've had less too. I've had less. So, talking about high-grade tumors in the intraaxial area, but now in the infratentorial compartment, you have your medulloblastoma. So it is the most common malignant neoplasm of the CNS in children, and all adult medulloblastomas are also considered WHO grade 4. So again, these are located at the posterior fossa, infratentorially, at the cerebellar vermis for kids, and in your cerebellar hemispheres for adults. Now these patients usually present with headache, ataxia, gait disturbance, nausea and vomiting, dizziness and vertigo, and diplopia. So diagnostic imaging, so locations are predominantly midline, they're vermis in children, and they are more hemispheric in adults. So on MRI, these are homogeneously contrast enhancing. When I say homogeneously enhancing, like the whole tumor enhances uniformly with contrast. Unlike heterogeneously enhancing, is just patches of it will enhance. Some very bright, some not bright. So just uniformly enhances, I guess, is what I'm trying to say. It's more frequent in children and may not be as common in adults. May appear as hypointense on T1 weighted MRI, but it's variable on T2 weighted MRI. This is if it's not contrast enhanced. Now, for an example, as you can see, that you have a midline mass. So let me pull out a pointer for you again. So these are all MRI sequences. So A, C, and D are T1 weighted contrast enhanced images of a medulloblastoma. So you see this is a uniformly homogeneously enhancing mass at the posterior fossa. Midline mass at the posterior fossa. And this B is a T2. This will most likely a T2 weighted image with no contrast. So this is T2, as in water, that's your CSF. Water, white, and 2, World War II, T2. So treatments of medulloblastoma. Completeness of resection is directly correlated with the outcome. An absence of residual tumor has been correlated with lower rates of progression or relapse. Radiation therapy for adult medulloblastoma typically consists of craniospinal radiation because these medulloblastomas are known to affect the spinal cord. Craniospinal radiation is given to those that are eligible to have radiation. But for kids younger than 3, I believe, you can't radiate kids under 3. So the usefulness of chemotherapy in treatment of adult medulloblastomas is not conclusively established. So we spoke about METs, like it's the most common intracranial tumor. And their incidence is rising because of increased cancer survival. So the most common source of brain metastasis in this patient group are cancer of the lungs and breast and melanoma, all in descending order. In children, the most common cause of brain mets is leukemia, followed by lymphoma. Keep note of that. So there is an increasing incidence of cerebral mets. This is due to the fact that there is increased length of survival of cancer patients as a result of improvements in treatment of systemic cancer. It's also due to the enhanceability to diagnose CNS tumors due to the availability of CT and MR. And of course, many chemotherapeutic agents used to treat the primary cancer cannot or do not cross the blood-brain barrier, which makes the brain, or the CNS, a haven for tumor growth. And some chemotherapeutic agents may transiently weaken the blood-brain barrier and allow CNS seeding with tumors. Now, imaging modalities for cerebral metastasis, particularly involve an MRI, and this is used to determine the number, location, size, and resectability of intracranial metastasis. MRI is more sensitive than a CT scan for detection of small metastasis or those within the posterior fossa. So MRI is still the ideal imaging modality for cerebral metastasis. So this is an MRI of a patient with cerebral metastasis. So again, this is T1 weighted because CSF is white on T1, contrast enhanced, as you can see here. So this isn't my tumor. I wish it was my post-op scan, but this is pre-operative, and post-operatively the tumor was excised. Most likely they passed with this burr hole here. They were able to pass through the posterior horn of the lateral ventricle to excise the tumor. So treatment of cerebral metastasis. So high-dose corticosteroids are used for the initial treatment of patients with symptomatic brain mets in order to decrease the edema that typically surrounds these tumors and to help restore neurological function. Headache, seizures, or symptoms of increased intracranial pressure show a complete response to whole brain radiation therapy in more than 50% of the cases. But durability of response at 1 year is only 65%. Cranial nerve deficits have also been reported to improve in more than 40% of patients who had whole brain RT. So surgery, the goal is complete excision of mets, and this will provide a large degree of palliation by immediately eliminating the effects of increased intracranial pressure. It also relieves direct irritation that the mets are causing to the surrounding brain parenchyma. It will provide us tissue confirmation for the diagnosis of the metastasis. And surgery may provide local cure if all the tumor cells are removed. Now moving on to, just bear with me a few more slides, to the extraaxial CNS tumors. So meningiomas. So the cells of origin is believed to be the arachnoid cap cells. These are usually globular encapsulated tumors. Attached to the dura and compress the underlying brain without invading it. Invasion of the dura and dural sinuses is common, though, and meningiomas are usually easily separated from the pia mater. So, just to show you the distribution of intracranial meningiomas, most common location of intracranial meningiomas is the convexity. Okay, based on this, then you have your parasagittal meningiomas, then your sphenoid ridge, then your intraventricular tuberculum cellae, then your infratentorial, then others. But the most common location is a convexity. So imaging modalities for meningioma. You have your CT scan. So meningiomas are typically isodense to slightly hyperdense compared to the brain parenchyma. Calcifications may be seen, and these are sharply marginated and usually broadly based against a bony structure or have a dural margin and usually have high contrast uptake. So this is a CT scan of one of my patients. You see the patient had a large left, so this is a contrast enhanced CT. So the patient had a large left frontoparietal convexity meningioma. It's quite large. I think the measurement, let me see, sorry, let me pull out a pointer. So this is a large left frontal convexity meningioma. I think I was measuring this for preoperative planning. I think it's 7 by 7. I didn't seem to get the depth, but I'm assuming it's 7 by 7 by 7. Anyway, as you can see here, it's against a bony base. So this is your bony base, this is your bony base. And usually they are adherent to the dura and they compress the underlying brain tissue inward. I think I did this case December 2020. Yeah, December 2020. And this patient was well. She went home without any neurologic deficits. Quite happy with this one. So another diagnostic imaging modality is an MRI. So you have a T1 weighted MR, which 60% of meningiomas are iso-intense on T1 weighted MRI, and 30% are mildly hypo-intense compared with the gray matter. On T2 weighted images, tumors are iso-intense or mild to moderately hyperintense. And of course, they all exhibit high contrast uptake. Oh, so this is an example. This isn't my patient. I just pulled this out of my book. So this is an example of a left frontal convexity meningioma on an MRI. As you can see here, you have your dural tail. So your dura is enhanced at the edges. That's your dural tail, which is very distinct for meningiomas. Another dural tail there. Or this is a very good example of a dural tail. As you can see here, the hypo-intense area, that's your cerebral edema. So this meningioma is compressing. It's extraaxial. It's out of the brain. It's not within the brain parenchyma. It is compressing brain parenchyma. So surgical treatment is the only definitive cure for meningioma, and complete resection is what we want. The more complete the resection, the less chance there is of recurrence, obviously. Now moving on to our last extraaxial CNS tumor, your vestibular schwannomas. So the most common lesion of vestibular schwannomas is at the CP angle, the cerebellopontine angle, and it's the most challenging tumor of the skull base. And vestibular schwannomas are associated with neurofibromatosis type 2. So lesions arise near the transition point between the glial and Schwann cells. In over 90% of the cases, the lesions arise from and remain confined to the inferior division of the vestibular nerve. So these patients usually present as hearing loss, tinnitus, disequilibrium. You'll have trigeminal nerve dysfunction, facial nerve dysfunction, because the facial nerve is really closely related to your vestibulocochlear nerve. And of course, hydrocephalus. Since this tumor is in the posterior fossa, it could impinge your fourth ventricle, causing hydrocephalus. So on CT, solid portions of the tumor are usually isodense, while cystic portions are hypodense on non-contrast imaging. This is a CT scan of a non-contrast CT scan of a patient with left cerebellopontine angle tumor. Most likely my patient too. So as you can see here, this is your fourth. Let me pull out a pointer, sorry. So as you can see here, this is your fourth ventricle. And this is your vestibular schwannoma or your CP angle tumor. So this is your right, this is your left. So you have your left CP angle tumor right there. So on MRI, these lesions are on T1 weighted sequence of an MRI. Two-thirds of vestibular schwannoma are slightly hypo-intense, and one-third are iso-intense relative to the adjacent brain tissue. T2 weighted images, vestibular schwannomas are heterogeneously hyperintense relative to adjacent brain tissue, and cystic airs contain fluid intensity. Post-contrast weighted T1 imaging show avid contrast enhancement, as we can see in the next slide. So this is an example of one of my patients, the same patient whose CT scan I showed earlier. This patient has a left CP angle tumor. Most likely this is the part that is going into your vestibular canal, your auditory canal. Your vestibular canal. We excised this. We were able to excise this tumor using a left retrosigmoid craniotomy. So we opened up through here, around this portion, and I removed a little bit of cerebellum to access the tumor. So treatment, emphasis over the decade has been on oncologic control as well as post-operative quality of life. Again, you have to weigh. There's really no point in excising the whole tumor if the patient is comatose afterwards. So it has to be a balanced decision whether maximal safe resection that provides a good quality of life. You have to preserve preservation of hearing and facial nerve functions should be considered. So cases like these, large cases like these, as the patient I showed earlier, we did surgical excision. For patients who have smaller tumors that have around 1.5 cm, around 2 cm size tumors, radiotherapy is an option without any surgery. You have a good response rate, maybe around 75 to 85% response for tumors that are less than 2.5% overall. So I guess that's it. That's the end of my lecture. Uh, you know, I would have wanted. I'm very sorry if I wasn't able to meet with you personally for a Zoom class. We've just having been nonstop with the ORs. But should you have any questions, any clarifications, or any other tumors that you want me to discuss, please just let me know. I'd be happy to talk to you and give you more insight into the world of CNS tumors. So I guess that's it. Thank you for browsing through my lecture, and all the test questions will be taken from this lecture. So you just have to read it and understand it and listen to me talk, I guess. So thank you, and have a good day. Bye.